Hi everyone, in this video we will talk about IgA vasculitis, Henoch Schonlein Purpura. So, Henoch Schonlein Purpura or IgA vasculitis is the most common form of systemic vasculitis in children. 90% of cases occur in the pediatric age group. It is self-limited in the great majority of cases, and the disease is characterized by a tetrad of clinical manifestations, which are the first one being the palpable purpura in patients with neither thrombocytopenia nor coagulopathy. Palpable purpura, hence the name Henoch Schonlein Purpura. The second one is arthritis or arthralgia with acute onset. The third one, abdominal pain, which is usually diffuse with acute onset as well, and renal disease manifested by proteinuria and hematuria. Okay, so these are the four clinical manifestations that represent Henoch Schonlein Purpura. So IgA vasculitis or HSP, which is short for Henoch Schonlein Purpura, occurs primarily in the fall, winter, and spring, but rarely in the summer, possibly explained by the association of IgAV with infections. So we'll come to that later. Approximately 1/2 of the cases of IgAV are preceded by an upper respiratory tract infection, especially those caused by streptococcus. So that is the reason why it is mostly in fall, winter, and spring. Other infectious agents, vaccinations, and insect bites have been implicated as possible triggers for IgAV. In a systemic literature review, it was noted that a majority of the studies had failed to show causal association between vaccinations and vasculitis, including IgA vasculitis or Henoch Schonlein Purpura. So what we know is 1/2 of the cases are preceded by an upper respiratory tract infection, especially those caused by streptococcus. The rate of IgA vasculitis is significantly higher, approximately 5% in patients with familial Mediterranean fever. Okay? So moving on to the pathogenesis. IgA vasculitis or Henoch Schonlein Purpura HSP is an immune-mediated vasculitis associated with IgA depositions, hence the name IgA vasculitis. Although a variety of infectious and chemical triggers are recognized, the underlying cause of IgA vasculitis remains unknown. Immunologic, genetic, and environmental factors all seem to play a role. The human leukocyte antigen, HLA, region as well as polymorphism in other immune-related genes are associated with IgA vasculitis, sometimes with conflicting results, which could be due to difference in ethnic and environmental factors. Although numerous case reports of IgA vasculitis occurring after vaccination, research studies suggest that vaccinations are not a major etiologic factor in IgA vasculitis and therefore should not be avoided. So now for the clinical manifestations in children, they may develop over the course of days to weeks and may vary in their order of presentation. The mean age of onset of IgA vasculitis or HSP is 6 to 7 years. Purpura is the presenting symptom in approximately 3/4 of patients, preceding other symptoms by a mean of 4 days in one series. As for arthralgia or arthritis, in most of the series, joint symptoms were the second most common manifestation, occurring in slightly over 1/2 to 3/4 of the patients. As for abdominal pain, which is colicky in nature, presented approximately in 1/2 of patients, and gastrointestinal bleeding in approximately 20 to 30% of patients. As for renal disease, the frequency of renal involvement ranged from 21 to 54%. So moving on to the details of skin manifestations. So the rash is, as we said, the presenting sign in approximately 3/4 of patients. It often begins with erythematous, macular, or urticarial wheals. It may be itchy but is rarely painful, and it may coalesce and evolve into the typical ecchymoses, petechiae, and palpable purpura. Typically appears in crops, symmetrically distributed, and located in primarily in gravity or pressure dependent areas such as the lower extremities. The buttocks are often involved in toddlers, and the face, trunk, and upper extremities in non-ambulatory children. So the other skin manifestation is localized subcutaneous edema, which is a common feature. It happens in dependent and periorbital areas, especially in younger children less than 3 years of age. Even adult patients may also have this manifestation, particularly involving the dorsal aspect of the hands. Blistering eruptions may also occur. So moving on to arthritis or arthralgia. It happens in 84% of patients. They are uncommon as the sole symptom at presentation, and they are the presenting symptom in approximately 15% of patients. It can be transient or migratory, typically oligoarticular, meaning affecting 1 to 4 joints, and non-deforming. It usually affects lower extremity large joints such as hips, knees, and ankles, or less commonly the upper extremities such as elbows, wrists, and hands. There is often prominent periarticular swelling and tenderness, but usually without joint fusion, erythema, or warmth. Patients may have considerable pain and limitation of motion. Younger children with lower extremity involvement may refuse to ambulate. It does not cause any chronic damage, and it may precede the appearance of purpura, usually by no more than 1 to 2 days. As for the gastrointestinal symptoms, which occur in approximately half of children with IgA vasculitis or Henoch Schonlein Purpura, it can range from mild to more significant findings, mild being nausea, vomiting, abdominal pain, and transient paralytic ileus, to more significant findings such as gastrointestinal hemorrhage, bowel ischemia and necrosis, intussusception, and bowel perforation. GAIA-positive stool is found in up to 56% of patients, but massive gastrointestinal hemorrhage is rare. The frequent presence of fecal occult blood, increased stool alpha-1 antitrypsin, and hypoalbuminemia without proteinuria, even in patients without gastrointestinal symptoms, suggests that gastrointestinal involvement and mucosal injury are more common than the clinical history indicates. It typically develops within 8 days of the appearance of the rash, although much longer intervals, weeks to months, have been described. Gastrointestinal complaints precede the rash in approximately 15 to 35% of cases, which makes it more difficult to diagnose IgA vasculitis when gastrointestinal complaints are the presenting symptom. Gastrointestinal pain associated with IgA vasculitis or Henoch Schonlein Purpura is caused by submucosal hemorrhage and edema. Purpuric lesions may be seen on endoscopy, commonly in the descending duodenum, stomach, and colon. The terminal ileum may also be involved. Submucosal edema, ulceration, and spasm of the ileum and jejunum may be seen in small bowel series. Intussusception is the most common gastrointestinal complication of IgA vasculitis or Henoch Schonlein Purpura HSP. Rarer gastrointestinal manifestations include acute pancreatitis, gallbladder involvement, bowel perforation, and in children, protein-losing enteropathy. So moving on to the renal disease. It happens in 20 to 54% of children with IgA vasculitis or Henoch Schonlein Purpura HSP. It is more prevalent in older children and adults, and the most common presentation is hematuria with or without red blood cell casts and mild or no proteinuria. Nephrotic range proteinuria and elevated serum creatinine and/or hypertension are present in a minority of patients. These findings, as well as the coexistence of hematuria and proteinuria, are associated with an increased risk of progressive disease, which occurs more frequently in adults. The findings on renal biopsy are identical to those in IgA nephropathy. The presence of microscopic papillary dermal edema and perivascular deposition of C3 on direct immunofluorescence of skin biopsy samples may be associated with development of renal involvement. Moving on to other manifestations, the scrotum can be involved in 2 to 38% of patients, and rarely the scrotal pain may be the presenting symptom. Clinical findings include pain, tenderness, and swelling of the involved testicle and/or scrotum. The presentation may mimic testicular torsion. Ultrasonography and technetium scanning can differentiate the two entities. In testicular torsion, these studies demonstrate decreased blood flow to the testicle in contrast to the normal or increased flow seen in boys with IgA vasculitis or HSP, Henoch Schonlein Purpura. Central and peripheral nervous system can be involved. It can manifest with headaches, seizures, encephalopathy, both hypertensive encephalopathy and posterior reversible encephalopathy syndrome, focal neurologic deficits, ataxia, intracerebral hemorrhage, and central and peripheral neuropathy. Most of the CNS findings are transient, except for occasional permanent sequelae associated with hemorrhagic stroke. Respiratory tract can also be involved. Patients may have impaired lung diffusion capacity and mild interstitial changes on chest radiographs, despite the absence of significant respiratory symptoms. Severe lung involvement, such as pulmonary hemorrhage, is rare and is primarily reported in adults and adolescents. As for eyes, keratitis and uveitis are rare sequelae of IgA vasculitis and usually suggest other diseases. For the skin manifestations in adults, intussusception is rare and adults are at increased risk for developing significant renal involvement, including end-stage kidney disease. Now moving on to laboratory findings of IgA vasculitis or Henoch Schonlein Purpura HSP. There is increased serum IgA levels in 50 to 70% of patients. Higher levels are associated with renal involvement. Findings on routine blood tests are non-specific. Patients may have a normal chromic anemia because of occult or overt gastrointestinal bleeding. Other results, such as markers of inflammation, generally reflect the triggering condition. IgA vasculitis HSP following bacterial infections is more likely to be characterized by leukocytosis and an elevated erythrocyte sedimentation rate ESR. IgA vasculitis after viral illnesses, on the other hand, often fails to demonstrate elevation of acute phase reactants. Prothrombin time PT, partial thromboplastin time, PTT, bleeding time, and platelet count are usually all normal. The initial urinalysis is also typically normal, although proteinuria and/or hematuria may develop over time. Hypocomplementemia, more in patients with recent streptococcal infections, which means decreased levels of complement component 3, C3, and/or complement component 4, C4. Complement levels in the study normalized after 3 months in all patients, and they did not correlate with disease severity or presence of nephritis. So moving on to the diagnosis. The diagnosis is straightforward when patients present with the classic signs and symptoms, palpable purpura of the lower extremities and buttocks in combination with 2 or more of the other typical disease manifestations. In patients with incomplete or unusual presentations, a biopsy of an affected organ, such as a skin or kidney, that demonstrate leukocytoclastic vasculitis with a predominance of IgA deposition confirms the diagnosis of IgA vasculitis or Henoch Schonlein Purpura HSP. Skin. The biopsy should contain skin lesions that are less than 24 hours old, because in more chronic lesions, vessel damage leads to nonspecific leakage of all isotypes of immunoglobulin. Immunofluorescence studies, essential to confirming the diagnosis of IgA vasculitis HSP, generally require biopsy of a second skin site. In the kidney, there is IgA deposition in the mesangium on an immunofluorescence microscopy that is identical to that in IgA nephropathy. Light microscopy changes range from isolated mesangial proliferation to severe crysenteric glomerulonephritis. As for laboratory tests, no laboratory test is diagnostic for IgA vasculitis, HSP. However, confirmation of a normal platelet count and coagulation studies are necessary when clinical features do not allow conclusive distinction of IgA vasculitis from other diseases that present with purpura due to thrombocytopenia or coagulopathy. As for the differential diagnosis, petechiae and purpuric rashes may be associated with septicemia, immune thrombocytopenia ITP, hemolytic uremic syndrome, leukemia, coagulopathies such as hemophilia, but normal platelet count and coagulation studies differentiate IgA vasculitis HSP from these entities. However, there are several other conditions that may present with purpura with normal platelet counts and coagulation studies, such as acute hemorrhagic edema of infancy, also known as Finkelstein or Stiglmaier disease, is a leukocytoclastic vasculitis described in children between the ages of 4 months to 2 years. It is a self-limited disease that presents with fever, purpura, ecchymosis, and inflammatory edema of the limbs and resolves in 1 to 3 weeks. Involvement of the kidney and the gastrointestinal tract is uncommon, but when it occurs, it is very similar to that seen in IgA vasculitis HSP. Biopsy of the skin demonstrates a leukocytoclastic vasculitis with occasional IgA deposition. It is unclear whether this condition is truly a separate entity from IgA vasculitis or actually overlaps with it. So hypersensitivity vasculitis, which is an inflammation of the small vessels that occurs after exposure to drugs or infection or without an identifiable trigger. Patients present with fever, urticaria, lymphadenopathy, and arthralgias, but not usually glomerulonephritis. Histopathology shows a leukocytoclastic vasculitis, primarily of the postcapillary venules, but IgA deposition is absent. Other small vessel vasculitides are uncommon in children. Laboratory evaluation of autoantibodies, including anti-nuclear antibodies, anti-double-stranded DNAs, and anti-neutrophil cytoplasmic antibodies, ANCAs, is typically negative in IgA vasculitis HSP. So moving on to arthritis and arthralgia. In approximately 15% of patients, they may be the presenting manifestation, usually preceding the skin manifestations by only 1 day. Until a patient develops the classical purpura of IgA vasculitis HSP, other causes of joint complaints must be considered, including autoimmune diseases such as SLE, juvenile idiopathic arthritis JIA, and rheumatic fever, which all may present with joint symptoms like IgA vasculitis HSP. Assays for serum complement, anti-nuclear, and anti-dsDNA antibodies and rheumatoid factor are typically normal in patients with IgA vasculitis HSP. Abnormal results for any of these studies may help to differentiate IgA vasculitis from SLE and JIA. Septic arthritis and toxic synovitis also may present with joint symptoms, like those seen in patients with IgA vasculitis HSP. These typically involve only one joint, unlike oligoarthritis involving several joints in IgA vasculitis HSP. Affected joints are also warm and erythematous in septic arthritis, unlike those in IgA vasculitis. Joint aspiration may be needed to differentiate the two. So as for the abdominal pain, distinguishing acute abdominal emergencies such as appendicitis from IgA vasculitis HSP may be difficult before purpura develops. Radiologic studies used to screen for surgical causes of abdominal pain are also used in patients with IgA vasculitis who develop gastrointestinal complications such as intussusception, bowel infarction, or perforation. Abdominal ultrasonography is indicated in patients with severe abdominal pain. It can detect increased bowel wall thickness, hematomas, peritoneal fluid, and intussusception. Contrast studies may miss intussusception in patients with IgA vasculitis or HSP. And renal disease. The manifestations of IgA nephropathy vary from microscopic hematuria to acute kidney injury. Although patients with IgA nephropathy do not have the other clinical characteristics of IgA vasculitis, these two entities may share a similar pathogenesis. So moving on to the management. Most patients with IgA vasculitis HSP recover spontaneously, and most patients may be cared for in the ambulatory setting. Therapy is primarily supportive and includes adequate hydration, rest, and symptomatic relief of pain. Edema of the lower extremities, buttocks, and genital area is improved with bed rest and/or elevating the affected area. Now, pain can be treated with acetaminophen or nonsteroidal anti-inflammatory drugs, NSAIDs. Glucocorticoids are indicated when symptoms are severe. Patients with HSP who have gastrointestinal involvement, including bowel wall edema, may have disrupted absorption of enteral medications. Thus, failure of NSAIDs or oral glucocorticoids to benefit certain patients may be due to poor absorption. Mild to moderate pain can be treated with NSAIDs, but NSAIDs may be contraindicated in patients with active gastrointestinal bleeding or glomerulonephritis because of their effect on platelets and renal perfusion. Naproxen, 10 to 20 milligrams per kg, divided into 2 doses per day. In adolescents and adults, a maximum total daily dose of 1,500 milligrams may be used for a few days. For longer-term use, a maximum dose of 1,000 milligrams per day is suggested. Ibuprofen and other NSAIDs may be similarly effective and may be better tolerated in some patients. Severe pain can be managed with prednisone, 1 to 2 milligrams per kg per day, a maximum dose of 60 to 80 milligrams per day. In patients who cannot tolerate oral medications, we administer equivalent doses of parenteral methylprednisolone. IV methylprednisolone may be more beneficial early in the disease course, when patients have active gastrointestinal disease due to submucosal edema and hemorrhage altering absorption of oral medications. When glucocorticoids are used for treating IgA vasculitis HSP, it is important to remember that although the inflammation may be ameliorated, the pathophysiology of the disease does not appear to be altered. Glucocorticoid dose must be lowered slowly, typically over 4 to 8 weeks, to minimize the chance of triggering disease rebound from rapid medication tapering. Patients who are treated with glucocorticoids for severe abdominal pain require vigilance, since these medications can obscure the signs and symptoms of abdominal catastrophes, associated with IgA vasculitis HSP. Hospitalization is warranted for the following indications in patients with IgA vasculitis HSP. The first one being inability to maintain adequate hydration with oral intake, severe abdominal pain, significant gastrointestinal bleeding, changes in mental status, severe joint involvement limiting ambulation and/or self-care, renal insufficiency, elevated creatinine, hypertension and/or nephrotic syndrome. IV hydration and nutrition is provided in the hospital setting if the patient cannot maintain adequate oral intake of fluids. Hospitalized patients also are monitored for potential complications from their disease. Frequent assessment of vital signs, urine output, and hematocrit, as well as serial abdominal examinations and stool examination for blood are required. Significant anemia may require red blood cell transfusion. Blood loss from hemorrhage into the skin, gastrointestinal tract, or urine rarely depresses red blood cell levels enough to necessitate a transfusion, although superimposed decreased production due to inflammation may result in symptomatic anemia. Abdominal examination consistent with either signs of obstruction or peritonitis, surgical abdomen, require prompt evaluation including surgical consultation and/or intervention for possible intussusception, bowel infarction, or perforation. Abdominal ultrasonography is typically used because it can detect changes in bowel wall thickness, hematomas, peritoneal fluids, and intussusception. Acute changes in behavior or mental status require evaluation for a potential intracranial complication, such as a hemorrhage. Patients with renal disease may be hypertensive and require antihypertensive therapy. Close monitoring of fluids and electrolyte management is imperative in patients with decreased renal function. Patients who present with nephrotic syndrome, hypertension, or renal insufficiency are at increased risk for long-term renal morbidity. Patients with severe arthritis usually improve with the use of NSAIDs. When these medications fail, administration of oral or parenteral glucocorticoids would generally result in a rapid resolution of the arthritis. As for the prevention of complications, the use of glucocorticoids in patients with IgA vasculitis is controversial. In addition to the common side effects of glucocorticoid therapy, such as hyperglycemia, hypertension, weight gain, acne, immunosuppression, there are potential side effects of glucocorticoid therapy more specific to IgA vasculitis HSP, including the risk of obscuring the signs of compromised bowel viability if treatment is started after an intussusception has occurred, as well as masking signs of fever and pain. As a result, it is not recommended routine empiric glucocorticoid therapy for patients with IgA vasculitis HSP to treat symptoms or prevent renal or gastrointestinal complications. Treatment of recalcitrant disease. Additional therapies for the treatment of recalcitrant disease are not well defined, but there are reports and case series that suggest benefits from medications such as colchicine and dapsone. There are also reports of benefits from additional immunosuppression in cases of aggressive recalcitrant disease, typically with renal involvement. So as for the prognosis, the short and long-term outcomes of children with IgA vasculitis HSP are generally excellent. In the absence of significant renal disease, the initial episode of IgA vasculitis typically resolves within 1 month. In 2/3 of children, there are no recurrent episodes. In the remaining 1/3 of patients, IgA vasculitis Henoch Schonlein Purpura HSP recurs at least once, typically within 4 months of the initial presentation. Each subsequent episode has similar clinical manifestations but is generally milder and/or shorter in duration than the preceding one. Presence of an infectious trigger was associated with a lower likelihood of relapse, while the risk of relapse was higher when joint and gastrointestinal symptoms were present. Recurrences are more common in patients with nephritis, in those with evidence of acute inflammation, elevated ESR, and in patients who received treatment with glucocorticoids. One study found that persistent hematuria was a predictive factor for relapse. Another study found that development of nephritis was associated with persistent purpura and gastrointestinal bleeds. Morbidity in the initial phase of IgA vasculitis is primarily a result of gastrointestinal complications, including intussusception and, less commonly, bowel ischemia, bowel perforation, or pancreatitis. The long-term morbidity in patients with IgA vasculitis HSP is a result of renal disease. The risk of chronic renal disease is increased in adults. The severity of renal involvement correlates with the severity of the initial renal presentation and histologic changes seen on renal biopsy. Risk factors for a worse renal prognosis include nephrotic range proteinuria, elevated serum creatinine, hypertension, and certain histologic findings. As for the follow-up, 90% of children who develop renal involvement do so within 2 months of onset, and 97% within 6 months. Adults are at higher risk for renal disease both early in the course of disease and longer term. All patients with IgA vasculitis HSP should be followed with urinalysis and blood pressure monitoring weekly or biweekly for the first 1 to 2 months after presentation. Additional follow-up for urine and blood pressure monitoring should be scheduled monthly at first, then every other month until 1 year after the initial presentation. To identify patients who may develop late renal disease, continued screening, such as urinalysis and blood pressure measurements, should be performed by the primary care clinician during subsequent annual well-child visits. A serum creatinine should be obtained to assess renal function in any patient with significant or persistent urinary abnormalities or elevated blood pressure. Patients with persistent proteinuria, hypertension, or renal insufficiency should be referred to a pediatric nephrologist for further evaluation and treatment. Pregnant women with a history of IgA vasculitis HSP should be monitored closely as they have a higher risk of hypertension. Close observation and frequent abdominal exams are recommended, in addition to follow-up imaging for patients who presented with abdominal pain and required treatment with glucocorticoids, especially if the patient has hematoschisia, persistent abdominal pain, guarding, or other significant change in the physical exam. And that concludes our video. Thank you so much for being here and for watching the video till the end. Please like, share this video, and subscribe to my channel to get the latest videos. Thank you so much.